So, cardiac output, the main focus of our next 2 weeks, believe it or not. This week, we are focused on classic measurements of cardiac effort. How do we measure cardiac function? There are a number of different ways that we can do that clinically, a number of better ways than the way that we're going to do in lab, but also a number of more expensive ways that require a high degree of skill. So we'll review those or introduce those in this lecture today, which will set the stage for our understanding of flow in general. And then a large portion of this block of slides is spent understanding the indirect Fick method, which is part of the Fick principle, which relates flow to concentration, and we can calculate flow at the whole body level using the indirect Fick equation. There are a number of somewhat complicated calculations. They're outlined in the lab manual. They are in the slide set in detail. I've often even run like a brief tutorial after lab in previous years. Bring your lab data to class, because as we go through step by step, you could even try to work on your own data here. It's the exact same breakdown and procedure, and you'll see it 2 or 3 times. But there are a number of calculations. I will try to describe the calculations to you as best as possible rather than just throwing equations at you and numbers and symbols. I'm going to try to tell you what the equations mean to help maybe understand it a bit better. But that's coming. That I want to save till Thursday. Today is really a discussion of these clinical assessments. Different kinds of stress testing, an angiogram, echocardiogram, and there's a number of really informative videos and some actually new cutting edge stuff for clearing blockages in any artery in the body that I'll show you today. So why would we ever need to measure cardiac function? We already have ECGs. We've done a 12-lead assessment, and we can get a pretty good handle on if there's any defects at the gross electrophysiology level. But if there's ever a case where ECGs don't demonstrate abnormalities, or if ECGs demonstrate something that's not clear, then you'll want to look more invasively. And part of that understanding of cardiac function is perhaps there's no defect in our ECG trace because at rest the stress on the heart is quite low. Maybe a patient would complain about symptoms, shortness of breath, or chest pain, mild chest pain, but to the best of our understanding, the ECG doesn't show anything. And so how can we evaluate cardiac function to determine what is actually going wrong and where it's going wrong? And the first thing that you might do is perform a cardiac stress test, which monitors ECG as you increase the workload of the heart, essentially. We want to see if there are potential abnormalities that are generated at higher workloads, that are generated when the heart has a higher duty cycle or it needs to do more work. We increase the workload of the heart while monitoring ECG changes to evaluate any potential abnormalities. Often this will help reveal anything that's hidden at rest. And there are other tests that you can do, and we'll talk about some of them coming up. But there are other tests that you can do to evaluate where an issue is localized or what the effect is. But this is one way to differentiate between the seeming non-appearance of symptoms at rest, but the complaints by the patient. So we increase the workload to reveal any abnormalities. There are limitations, though. Often this is symptom limited. And if your focus is only to understand what type of work a person can tolerate really all we care about is where the symptoms limit exercise. You simply don't want to have them exercise above that point, right? If their symptoms limit function, limit exercise at a certain intensity or a certain percent of VO2 max, you just don't go above that point. So these are often symptom limited. And there's a nice utility there from an applied point of view, from a prescription point of view. But that applied point of view doesn't tell us much about the workings of the heart, the inner workings of the heart. And maybe this isn't a focus that you'll ever come back to in your professional careers, but it's interesting to travel down this rabbit hole a little bit to understand how the heart might be working or what might be going wrong. So some limitations to the stress test is that it's only focused at the whole body level. You can't see in other than through the ECG, and that might be limited. But you certainly can't localize any specific vascular issues. Is exercise symptom limited because there are flow deficits at the heart or at a peripheral vessel, at the brain, for instance? Are they experiencing dizziness? So we don't know where these vascular deficiencies are localized. We're approaching the rest of this as if it were the heart, but acknowledge that there could be issues with the brain and other tissues as well. If we consider thinking about, or continue thinking about the heart, we can't localize vascular issues, and a common vascular issue is that of atherosclerosis, so blockage in the artery due to the buildup of plaques. So we can diagnose exercise intolerance, but we can't say why. Is there something wrong with the artery, or is it a buildup of plaque due to sedentary lifestyle and improper eating? Where is it? We don't know at the whole body level. And it's possible, what we have down here, we don't know what this means yet, this little figure, but we have essentially a depiction of blood flow. And where it's colored, there is blood. Where it's not colored, there's no blood. And this is a picture from the apex of the heart looking up or looking down through the ventricle. So the circle is the wall of the ventricle. In the middle is the cavity where blood pools to be pumped out. And there's obviously a difference here. There's no bright wall on the right-hand portion at the top. So we can get a sense from some mysterious diagram like this where blood flow might be in the heart, but we can't diagnose that with a stress test. And even if we have our 12-lead ECG hooked up, it doesn't measure blood flow. It only measures electrical activity. And true, electrical activity will be compromised if blood flow is compromised or if that tissue is hypoxic. Maybe we can get a sense that in one area there seems to be a deficiency that accumulates, but maybe there's just a uniform decrease in blood flow. Maybe the major coronary arteries are both blocked, and so the heart simply doesn't receive enough blood, and that's global. So there's a lot of things about the inner workings of the heart that we can't assess with a simple graded exercise test or a stress test. And usually as clinical exercise physiology, that's where our expertise will end. But you might work with individuals that use other types of tests, or you might have to interpret the results or contribute your agreement or interpretation of other results, like the nuclear stress test, which is that colored picture that we just looked at. A nuclear stress test can measure localized blood flow. It gives you a very nice detailed picture of the areas of the heart that receive blood. And it does this through the injection of a radioactive tracer and then monitoring where that tracer appears. This is probably a fluoroscope, but it can measure in general the area of the heart and the regions of the heart with blood flow. It can't differentiate individual arteries, which could be a problem, but at least we can tell if the tissues are perfused. Full perfusion in the ventricles on the left. We have an example of, I don't know if that's lateral or medial, left or right, but one side is deficient. The bottom is deficient in this fourth example. Another example where the side of the heart is deficient. I'm assuming that it's all looking at the ventricle head on and not from the side. But you can see wherever there's no bright spots, there is a lack of blood flow. And that's often something that we don't want to see at the heart. We can get some useful information from this. The intensity of the color will tell you how much blood is there. The thickness of the band of color will tell you the area that's perfused. The area contained, if you can identify where the ventricle is, the area that's contained gives you an idea not of muscle perfused with blood, but the size of the ventricle, the amount of blood that might be pumped. So you can get a rudimentary understanding of stroke volume. And if you can string together a number of these pictures, at systole and diastole, you might be able to even calculate or approximate the amount of blood that's being ejected. You can measure what's called or calculate what's called the ejection fraction. The ejection fraction is simply what's the difference between a full ventricle and an empty ventricle, which is also essentially stroke volume. Stroke volume is the absolute volume of blood, whereas the ejection fraction is stroke volume as a percent of the full ventricle volume. But if you have an assessment like that, and you know heart rate, you can pretty easily calculate cardiac output, which we are going to be measuring and using as our measure of whole heart function. We'll think of it that way. Kind of like the VO2 max test is to cardiovascular fitness, cardiorespiratory fitness. Cardiac output will be our measure of cardiac fitness at the whole heart level. And we'll talk about how that should change with exercise and what values should be, what they should look like. There's also some nice ways that we can even approximate it. There are some estimating equations that you can use with VO2 to ballpark flow. Verify if the calculations you go through in 18 different steps are actually close. But the point is we're getting more information about the heart. General areas that receive blood. But again, you can't tell if one coronary artery is blocked or where it's blocked or what degree of blockage there is. We just see muscle that's perfused with blood. So if we want information on the vasculature, we need an even more detailed diagram. An even more detailed assessment. What we would use would be an angiogram, where we inject an opaque dye and we visualize by X-ray the vessels of the heart. So we can visualize static images by X-ray. We can use a fluoroscope to measure this in real time, so you can measure the beating of the heart and flow in the arteries and how the arteries move as the heart beats. And I'll show you a video of that. But it allows us to see a blockage. We can actually see a blockage. If this is, let's call this the lateral coronary artery. If there's ever an impingement, it would be obvious because the opaque dye wouldn't fill the entire artery. It would look like it was pinched off. You could tell how pinched off, you can tell where it is, and this will help guide treatment to that specific location. And the treatment that we would refer to, a general class, is called angioplasty, which could simply be pushing the blockage out or pushing and securing the blockage or cutting the blockage away. There's a really neat new development that essentially vacuums the blockage away. And all of these I have examples for, so if it doesn't make sense now, we'll see them. But this is where you would have localized surgery, a procedure, to correct a blockage using stents, balloons, or atherectomy, which is removing the damaged tissue or the blocked tissue. So let's take a look at some of these and how they work. We'll first look at the angiogram itself, because this static image, while it's really nice to see all the detail, seeing it in action, I think, is a bit more revealing.
Cardiac catheterization is an
This is from the point of view of the patient that's getting a procedure.
Often done to identify any narrowed or clogged coronary arteries that are preventing blood from reaching the heart muscle. The study can also be used to measure the size and function of the chambers of the heart and the function of the heart valves. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor, and you may be given an oral or intravenous sedative to help you relax. Most coronary angiography procedures last between 1 and 2 hours. Before the procedure, you will be placed on a table equipped with a fluoroscope, an X-ray imaging device. During the procedure, the fluoroscope will move around your chest in all directions to record pictures of your heart and coronary arteries from multiple angles. Most cardiac catheterizations take place through the femoral artery in the groin, but can also be done through an artery in the arm. The doctor numbs the skin in your groin area and inserts a needle into your femoral artery. Once the needle is placed, a wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath that permits access to your femoral artery. Next, a soft, flexible catheter will be slipped over the wire through the sheath and threaded up to your heart. Your physician will watch the movement of the catheter on the fluoroscope. You may feel pressure as the wire and sheath are inserted, but you will not feel their movement inside your arteries. To evaluate the coronary arteries, your doctor will remove the guide wire, position the tip of the catheter just inside the arteries, one at a time, and inject a special dye. This dye allows the fluoroscope to take X-ray images, called angiograms, of the artery's interior. Any blockages will be clearly identified as the arteries fill with dye. You may feel flushed or slightly nauseated when the dye is injected. After sufficient images of both coronary arteries and their tributaries have been recorded, the catheter will be removed through the groin. Pressure must be applied over the femoral artery to prevent bleeding. You will then be taken to the recovery room for 30 to 60 minutes of observation, after which you will be required to lie on your back for several hours with a pressure bandage in place over your groin. You may either be discharged home on the same day or after an overnight stay in the hospital.
Seems logical. Put pressure on the femoral artery, make sure that you don't bleed out. Pretty involved process, though, right? And you wouldn't often consider how you would access the heart, but you probably don't want to go right through the thoracic cage and into the heart tissue. You don't want to go through the aorta. You probably need to go from a peripheral vessel. And even the pressure in the arteries, the femoral artery or the brachial artery, it's still 120/80 or whatever the pressure is generated by the heart. It's a lot of pressure. We did some arterial catheters not as part of my study, but another student that was doing a study during my doctorate. And normally you get a catheter in an arm vein, and you have to put one of those vacuum tubes on to create suction, or you have a what's the name? Not the needle. Syringe, that's the one. Or you have a syringe that you try to extract blood from. But as soon as you have an arterial catheter and you put the syringe on and you open the stopcock, it pushes the plunger right out. You have to stop the plunger from coming out. There's so much pressure. So, invasive, right? And that's going to come back up when we talk about how we would theoretically measure cardiac output. So we have a nice picture of any potential blockages, and you can imagine what it would have been like. Imagine being at the blockage and trying to be a red blood cell forcing your way through, and you have all of these other blood cells around you and this fluid trying to force its way through. Not everyone can fit through, so flow is reduced. There's shear stress on the walls. It's a pretty serious scenario. So if you see a blockage, or if a blockage needs to be treated, how is that classically done? And a lot of this repeats the same angiogram information, but we have some nice info on how to treat a blockage in this video. So this is our blockage, and this is how we would classically treat a blockage.
Once the blockage is identified, a flexible guard wire is inserted into the artery vessel, followed by a balloon-tipped catheter over this wire to position itself at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing the flow of blood in the artery. After the blocked vessel is reopened, the deflated balloon catheter is withdrawn from the artery. The same treatment procedure is repeated in the case of multiple blockages. Most patients may also receive a coronary stent, which is a small tube made of wire mesh designed to keep the artery open once it has been treated. A collapsed stent is placed over the deflated balloon catheter as it is inserted into position. When the balloon is inflated, the stent expands and locks itself into place. The deflated balloon and catheter are withdrawn, leaving the stent behind to hold the artery open permanently. Post-treatment, a pressure bandage is...
So that describes the stent procedure. Depending on the severity, the stent will be applied, because you can imagine if you just open up the blockage and you don't do anything to remove the plaque deposits on the walls, the epithelium is going to be fairly weak, or weaker than it would be otherwise. You're stretching the epithelium. And if the blockage is large, this can protrude pretty far into whatever the extravascular compartment is. I actually saw in the anatomy class that I was in undergrad, our donor had an aortic aneurysm that we discovered through the dissection process, which is blockage in the aorta, which is one, it's rare because the aorta is high flow and high pressure, and it's not often that you would accumulate inflammatory factors or plaques on the walls of the aorta. And it's a big, thick, strong vessel, inch in diameter, thick walls, elastic walls. So it's, I'm not going to say not susceptible, but it's not common to see that in the aorta. And it looked, when we opened up the thoracic cage, it took the lungs out, it looked like there's a candy cane of the aorta and then just ribbons. And the aorta was, where it should be an inch in diameter, was probably 4 to 5 inches in diameter. And the cross section looked like rings of a tree. And the area for blood flow might have been a centimeter, half a centimeter. And so it's just this plaque building up in rings that pushed the aorta outwards, cut off blood flow. Not something you could even fix with a balloon or a stent, I don't think, but was the reason that this lady died, unfortunately. But just incredible to see how far it can progress. You see like a nice cartoon like this that shows a small blockage, but it's pretty striking that it can progress so far. So walls are weakened. In the extreme case, walls can rupture, which you don't want. So the stent helps to make sure that the blockage doesn't collapse again. And a lot of new stents will even be coated with anti-inflammatory factors and factors that help the healing cascades or the clotting cascades so as to repair the inner walls of the vessel. It supports them, and then there's also factors that are applied to the metal as a coating that help to speed the healing process and prevent these plaques from simply building themselves up on the other side of the lattice work. I don't have a video for an atherectomy, which is a word that we saw a couple slides ago. But you can imagine while we have this slide up what it would be. Instead of using the balloon to push the blockage outwards, you would insert almost a rotating razor into the vessel. And that would just chew up in gradual rotating circles all of the blockage on the walls, which gets rid of the blockage, but you can imagine causes some pretty widespread damage. And we've moved away from atherectomy largely because atherosclerosis, the way that these plaques grow, is that they get too big and rupture, and then the healing process adds a new layer of plaque on top. Rupture, new layer. Rupture, new layer. And so by cutting out the blockage, we're essentially speeding the rupture, which forces a new layer of plaque to be deposited on top. So we don't do atherectomies as much anymore. What we have moved to that I think is kind of cool, and this was something that I found on Reddit like a week ago. So this is new 2018, a way that you can remove a pretty severe blockage in the heart or anywhere else. No narration on this one, unfortunately. But if you imagine here almost a complete blockage, and it's sort of ominous that the heart is beating in time as this video goes along, but what you're seeing is there's no flow, all the red blood cells are trapped, and we're anchoring this guide wire in the artery with this big latticework device at first, and essentially this is drilling through the clot. It'll drill through the clot, some is released, but not all of it is released. What happens is we'll send a balloon and a stent-like device through the hole, and then inflate it distal to the blockage, and then use this to pull back, chop up, and essentially vacuum the clot. We break everything up against this this anchor, I don't know, it's like a mesh anchor. All the factors, whatever the clot was, is broken into smaller pieces that can now travel through the artery. All of the red blood cells that were awaiting transport can now move through. And no idea if something like this will work for plaque within the walls, but certainly a blockage lodged in the arteries can be disposed of pretty easily and effectively with technology like that. I think that is not yet in clinical use, but still in its development stages. But just like remarkable that we can have such technology at such a small scale. The dexterity, the articulations that you need to do to be able to make these fine movements with these incredibly fine devices is really mind-blowing. So that really caps our discussion on arterial flow, or at least coronary flow. We're not coming back to individual arterial flow. We're now looking at the level of the heart or at the whole body, but the principle can be applied to both, one individual artery and the heart as a whole. So does this make sense, the test that you might use and what you'd be looking for to assess cardiac function in a really fine detailed kind of way? Because we can't do that in lab, but we can measure the outcome of cardiac function, which is flow. That's the job of the heart, right? To pump blood. So measuring flow is our surrogate measure of cardiac function, and that's what we're going to be looking at in lab. And flow in the whole body, flow in any artery, would measure, or would mimic, coronary flow, or the flow in any specific vessel. So if you can measure part of the systemic or the systemic, flow should be the same. And because the heart's job is to pump blood, if we can measure flow and then compare it to what would be expected in a normal, healthy individual, we can somewhat evaluate if the heart is working properly or if the heart is working normally. We can measure flow locally. You can measure it at one coronary artery if you have a small device, a stent that you can insert into that artery. We can measure it locally. It's just very invasive. We're not doing that in lab. Our surrogate is a whole body systemic flow, but they should parallel one another. And flow is described here in this cartoon. This drawing represents the original Hagen-Poiseuille equation, which has the original intention of determining the pressure gradient across a tube. So it's all for measuring flow through a tube. And this is often used in plumbing or anything that involves long hollow cylinders that convey fluids or liquids, fluids or gases. So originally its intent was to determine what the pressure difference was across a tube or a system of tubes, but we're simply adapting this for our purposes to measure flow. And it's not immediately clear what all of these subscripts and symbols mean. I do list them on the next slide, so you're not going in totally blind. But all this says, if we focus on the second equation, and you don't really need to copy all of this down, like we're not going to put numbers in and calculate flow according to this equation. It's really hard to even figure out what viscosity is in a lot of cases. But essentially what this says is that, well, it's kind of small. Flow will be enhanced by really two factors. If there's a large pressure difference across the system, if we have one tube, it's from the beginning to the end of that tube. If we're looking at the whole body, it's from ejection of blood at the heart, so right as we enter the aorta, to the return of blood in the right atrium. Pressure difference. Flow is enhanced by a large pressure difference and a large radius. More area for flow means more flow can occur. And that makes sense. Both of those factors are on the top in the numerator portion of this equation. If they go up, flow goes up, if you want to think mathematically. And so by that logic, flow is reduced by any factors on the bottom. This subscript n and mu, they don't match up, but those are both meant to represent viscosity, mu and this n. So if a liquid is very viscous, that will impede flow. If it's gelatinous, it's hard to flow. And then the length of the system will impede flow as well, largely due to the shear stress at the walls that slows the flow down. And you can see that represented by the vector arrows within this tube. The greatest flow occurs in the middle, and we get progressive reductions in flow as we reach the edge, termed laminar flow. Perfect flow through a tube. Fast flow in the middle. That slows as you reach the periphery because the walls aren't moving. The walls are slowing down any liquid in that general area, and you see a progressive increase towards the center. Yeah?
So why is the length a problem? Like why decrease in length?
The length will decrease flow just because of the larger impact of shear stress. More length, a greater negative impact of shear stress on flow. The walls will try to slow down the fluid that's flowing in the vessels. And that's only quote unquote important on this slide as in the context of describing the influence on flow. We never really refer to length again because in the body, length is fixed. So we can forget about length. In the body, viscosity is also pretty much fixed, which is nice. So we don't have to worry about viscosity. Yeah, Razan.
The length, like the femur artery, for example, if it's a really long artery, like is that flow, like flow is reduced in that because of the length, or that's a mistake artery?
There might be more of an impediment to flow, but the flow of blood through the artery will be dictated by the difference in pressure and whether it's constricted. We have, I think, the greatest influence by far on whether flow will be increased or decreased in a portion of the vasculature is whether that portion is constricted or not, if it's constricted or open. That's how we direct flow through the body. So this won't have a large influence, and if it has an influence, it's fixed, it's static. And we'll get around that by opening the artery or closing the artery or increasing the pressure. So it's not that as blood comes down the aorta, it's moving at a certain rate, and then it stops. We're going to modify these other factors to allow continuous flow, if that makes sense. Okay, let's, I threw up a lot of detail on that slide, but we're going to simplify it. This is an old equation. This has been around and fixed for many, many centuries. 1800s, this equation was described, and really all it tells you is flow is a factor of pressure and resistance. Pressure and resistance. And so if I break up the equation that I just showed you, the original equation, flow is determined by pressure and resistance. Pressure is easy to understand. We've talked about pressure generated by the heart already. Resistance is less easy to understand. Everything else that's separate from pressure we term resistance. And resistance will have the radius as part of that term. Viscosity will influence resistance. The length of the tube will influence resistance. More often than not, these factors are fixed. When they're not fixed, it's usually radius that we're referring to that can modify the amount of resistance experienced by the body. That's why we kind of gloss over or we generalize resistance as what we call total peripheral resistance. We don't spend a lot of time calculating length or viscosity or the radius for reasons that we'll talk about coming up. Flow is related to pressure and impeded by resistance. So I separate pressure out of this equation. The resistance term, since it's divided by resistance, the resistance term is really shown here on the right. I could calculate resistance if I had the total length of the cardiovasculature. if I had the complete viscosity of blood, if I had the average radius of all of the vessels, I could calculate resistance according to this equation. But I'm not going to, and I'll tell you why. We don't care so much about average length or average radius. Mostly the length and radii serve a specific purpose. Radius is a lot smaller in the capillaries than in the aorta because they have a different role. We collectively refer to resistance as total peripheral resistance, and we don't calculate it using that resistance term I just showed you. Instead, if we calculate flow through the system and pressure in the system, we can get what must be total resistance in that system as well. So how might we calculate systemic resistance? We need systemic flow and systemic pressure. Now, on a beat-by-beat basis, these will change. If you think about it, during systole, as we eject blood out, there is flow that occurs, and that gradually must slow down. And actually, I'm not even sure if it would stop at a point after systole during diastole before the next beat occurs. Flow would be at its maximum as we're ejecting blood, and its minimum right before the next beat. Flow will oscillate, just like pressure will oscillate. Systolic pressure is higher, diastolic pressure is lower. So we need to acknowledge that, but if we can figure out what the average flow of the heart is and the average pressure in the vasculature is, we can figure out what the net resistance must be. And this is how we get to this classic physiological equation. Flow is mean arterial pressure over total peripheral resistance. Average flow in all of the arteries and veins in liters per minute is average pressure in the entire system divided by average resistance in the entire system as well. So this is the equation that we'll use. We're not concerning ourselves with pi and radius and viscosity and length. Most of those terms are fixed, but we can calculate these terms which contain smaller dimensions within them, but we don't care as much as long as we can approximate total resistance and average pressure. And we talked already about how to calculate average pressure last week. This series of slides deals with calculating Q. So in what ways can we calculate flow? We can't calculate flow from an ECG. We can't calculate flow from a stress test, a graded exercise test. We can approximate flow with the nuclear stress test, as we alluded to. We've seen a few small pictures, but we get a lot more information if you were to perform a nuclear stress test. You can estimate cardiac output or systemic flow by looking at all of the small changes over time in the ventricles. We can look at the change in the lumen volume, estimate the ejection fraction, and calculate flow accordingly. But that's a pretty labor-intensive process. Probably we have computers to do this and interpolate what the lumen volume would be and how it changes. But you need a lot of data to figure that out. You need to have continuous observation Watch as the lumen gets bigger, as it's filled. There seems to be some impediment to flow over here where the muscle isn't receiving any oxygen. But the change in the diameter would allow us to figure that out. And we don't only want to look in one axis. We need to look across the ventricles, from under the ventricles, in line with the ventricles. All of that data is used to calculate or approximate the ejection fraction. Labor-intensive process. Especially when you consider, to do all of this, maybe you encompass one beat of the heart. Is every heartbeat the same? No. The cardiac cycle is plastic. It speeds up and slows down even with an average normal resting heart rate. Filling and stroke volume will change beat by beat as well. Labor-intensive process. Many discrete images need to be compiled together. So it's hard to get it from a stress test, can't get it from an ECG, can't get it from a graded exercise test. We can get it from something called an echocardiogram, which has the downside of simply being more expensive. And I'd love to be able to pair this with our indirect FIC assessment in the lab at some point, if we ever find grant money lying around. Maybe as we make this new building and we move in, some money falls out of like a classroom somewhere that we can get one of these portable echocardiograms, and I'll show you what it looks like in 2 slides. But essentially, non-invasive, it's an ultrasound device where you can observe from the outside looking in, using sound waves, changes in the structure and function of the heart. So you can see in real time, valves opening, valves closing, ventricles enlarging, ventricles contracting. And a lot like the nuclear stress test information, there are computer programs that can calculate what ejection fraction must have occurred to have observed the changes in the ventricles that you see with the echocardiogram. And the focus of this picture is not so much to notice the amyloid deposits, which is really interesting because we're coming back to those when we talk about Alzheimer's. It's not to notice deposits in the heart. Here are the ventricles. I'm pretty sure those are the ventricles and those are the atria. It's to notice that the chamber size varies, can change. I'm assuming these are different parts of the cardiac cycle in different patients, but the chamber sizes change. So we can measure the ejection fraction as the percent that was expelled. These have even advanced further, where in real time they can show you flow. They can overlay a color gradient to indicate where flow is occurring. And not only where flow is occurring, but the direction in which flow is occurring. So any of the red, orange, yellow colors are flow towards the device. Any of the blue, light blue, white colors are flow away from the device. So you can see as flow pumps from the atria into the ventricles, there's flow towards and away, this turbulent flow and filling of the ventricles. And that can be used to approximate ejection fraction and stroke volume as well. Look at that level of detail. You wouldn't even know where to begin if you were trying to extrapolate that manually. And the gradients too, from no flow to, what is that, 75 centimeters per second? That's a lot of flow if you think about it. Wow. 75 centimeters per second. 3/4 of a meter in a second. Not bad. So let's take a look at the echocardiogram, and this is probably one of my favorite videos of the course. Come on, show me. What? There we go.
We're here with Malcolm Foster in the Echocardiogram lab. Malcolm, tell me about the echocardiogram. What do we see here?
Well, this is a very common procedure. It's an ultrasound test. So the person comes in, they lie on their side, and we take a microphone, an ultrasound transducer on the chest wall. It brings sound waves through and through the heart, and we make images.
So what kind of images are we looking for? Can you see a heart valve?
Yes, so we see all 4 heart valves, and the heart muscle, the sac around the heart, the aorta, all the chambers of the heart, the 4 chambers.
Do you see the heart muscle move? Can you see it contract as you do?
We do, and we can calculate the volume and the pumping function, the ejection fraction.
Is that one of the most important things that you get out of it, the ejection fraction, to see how strong that heart is beating?
Yes, very, very important.
Can you tell if there's a weak valve, a leaky valve, or a valve that's not letting blood go through it, a stenotic valve?
That's right. We can see both, and we can determine how severe. So it could be mild, moderate, or severe amount of stenosis or regurgitation, sticky valve or leaky valve.
Can we take a look at the echocardiogram?
Sure.
Malcolm, this is a real echocardiogram now. Tell me what you're seeing here. I see some black areas and some white areas. So tell me what part of the heart this is.
So we start with the pumping chamber of the heart, the left ventricle. So this is the pumping chamber, and the ventricle is normal in size. It's the heart muscle has normal thickness. The pumping function of the heart is normal. Then this is the mitral valve, where it allows blood flow into the left ventricle. This is the aortic valve, where the blood flow ejects from the heart into the aorta.
Now, can you tell if that aortic valve is leaking by just looking at this?
We can. So we would see if this valve were thickened and narrowed, it did not open properly, that would be stenosis. And then we apply color across there to see if there's any leakage of blood flow, backflow. And he does not have either.
Now, could you just walk down and do this in the abdomen and the legs and everything else?
We can do ultrasound of all the blood vessels, believe it or not, even from within the brain, the neck, the heart, the kidneys, down the legs.
Now, Malcolm, this is a very expensive machine right here. What are the chances that we could have this in every examining room when you come in just to see your regular doctor? What's available?
Well, it's actually available now. So there is a handheld device. It's about the size of a smartphone. And then the probe, which is attached by a cable, allows us to take the very same pictures, the very same images as an expensive unit that we have in the hospital.
So in the examining room, I could run this over my heart, and I could look at the valves on the smartphone.
That's right. So compared to a stethoscope, for example, we get much more information, much more detailed look at the heart with a handheld ultrasound.
Malcolm Foster, this is great. Thank you. It's been exciting for me.
Thank you so much, Dr. Bob.
Dr. Bob's enthusiasm cannot be beat. I love it. I love it. So, really nice view of how the echocardiogram works. And that's probably a preferable method to what you are going to have to go through in lab and all the calculations you have to do. Definitely a preferable method to many of the invasive measurements that we'll talk about here, and to the more expensive measurements, well, and invasive, like the angiogram. So this leads us to what I'm calling, quote unquote, old methods for determining cardiac output. And I thought that I had more information on this slide, but I guess I don't. I'll just describe what each of these are to you. Really, I'm only going to describe what dilution and thermodilution are. The direct and indirect fix are the focuses of the next section. We spend a lot of time talking about those. So I'll just describe dilution and thermodilution. The principles are very, very similar, and they're represented by the trace over on the right-hand side. So dilution is an old technique where you'd inject an inert dye into part of the vasculature. Indocyanine green was the dye. And then measure in a separate part of the vasculature when that dye came around, when it was circulated. And you can tell based on how quickly it was circulated and how dilute the dye is when you register, when you monitor it, how quickly flow must have occurred. So if you inject in the veins of the right arm, you would be monitoring at the arteries in the left arm. So you want it to go back through the heart, mix completely, and be sent out to all the arteries. Now you'll know how much of the dye was injected. That's measured and metered out. And what you're looking for is a curve like this over on the arterial side in the left arm that shows you when that bolus circulates. And so here I have a trace that says, okay, there's no dye in solution, no dye in the blood. All of a sudden I start to see some dye, and then boom, a lot of it passes, and then it continues on. So I'm looking in the artery, I'm sampling in real time, I see it pass by the sampling site, and then it's gone. And ideally, it should completely diffuse and there would be no more dye, but because the cardiovascular system is contained, you're going to have constant recirculation, which is what this little bump is over here. This is the second passing of the bolus, but it's mixed with blood from all over the body, so it's not nearly as concentrated as it was the first time. So what this tells us, the shape of this curve, if this is a very abrupt, fast spike, up and down, it tells us that cardiac output or flow is slow. Why is it slow? Because as the bolus is injected, the flow isn't pulling it apart. It's moving slowly and it's all inserted into one part of the blood. Think of it that way. It's carried along in one small pocket of blood. And then as it's registered at the sensor in the artery, all of it passes at once and then leaves. If cardiac output were fast, you would expect a much more gradual and lower spike in the dye concentration. The dye covers a larger volume of blood because blood is passing more quickly. And the same thing holds up for the thermodilution technique. So large spike, very contained, means slow flow. Small spike, small amplitude, wide or distributed measurement means fast flow. And the exact same principle applies to the thermodilution technique. Now the indocyanine green dye dilution was probably done most in the 50s through 70s. Sort of a mechanical way to get at flow. And thermodilution replaced it shortly thereafter. We don't use it as much anymore. The thermodilution does the same thing with one catheter. One purpose-built catheter. And the way the catheter works, I can't even draw it quickly in real time. But imagine, this is the best example I can give you. Imagine that the laser pointer is the catheter, and there's the long thread connecting it outside the body. This special sensor is what measures the thermodilution. And it does that by connecting to ice-cold saline somewhere outside. And you will inject ice-cold saline just like you injected the green dye and measure how quickly it diffuses. So if this is in line with the blood and blood is flowing across the laser pointer headed to your right, and I inject cold saline over here at the left-hand edge. Which way is the cold saline going to flow? To the right with the blood, absolutely. I have on my special purpose-built catheter a port on the right-hand side that will sample the blood, or sample the temperature of the blood. And so before I infuse or inject the cold saline, it's reading body temperature, 37 degrees. As soon as I inject the cold saline, all of a sudden this starts to read a lower value, lower than body temperature. Well, if it gets really cold, that means the flow is very slow. All of the saline is accumulating in one small pocket of blood. It's all registered at once by the sensor. The sensor gets very cold. If it registers a smaller deflection in temperature, spread out or prolonged, much like the dye, flow is much faster. The injection of saline into the blood occurs over a much larger volume. Blood is passing by really quickly. So in both cases, large deflections mean slow flow. And conversely, small deflections mean fast flow. In both cases. Very similar principle. Thermodilution, not likely to have this recirculation bit. The body's going to warm that saline, and it's not a large volume of saline that's injected, so it shouldn't come back as registering another cold pocket has passed. But the principle is the same. How quickly is the indicator dispersed? Question? Yeah.
It seems like thermodilution is something that's easier to repeat because you don't have the dye that kind of lingers around. So like with thermodilution,
Yes.
you could like compare repeatedly within the same trial.
Yeah, you could. You could make measurements acutely and isolated at different times during an intervention. Absolutely. The downside of either is that you have to sample arterial blood. So in the dye dilution technique, you're actually taking samples of arterial blood and then you put them in an analyzer and you're making this curve, so it takes a little while to build the curve. In the thermodilution technique, you're measuring in situ, so like in real time, but if you want to do many measurements over an exercise trial, you've got to keep the catheter there. And if you're doing exercise, if it's moderate to intense, I wouldn't really want, maybe you would, I wouldn't want a catheter in any artery. Not so bad if it's a peripheral artery. And flow in the periphery, that's a good question. Okay, so I was going to say flow in the periphery should mimic flow at the heart. But is that the case? You have more resistance. And could you just pick any artery in the periphery to measure flow? You have more resistance, and what about the resistance in the periphery? Let's say that I'm cycling, and I take a hand artery or a leg artery.
Yeah, it's because like if you're not using active muscle, then it's...
Overall, you have more resistance, and that resistance can vary greatly by what the active muscle is. Absolutely. So you can't just pick any artery, which means not only do you need an arterial sample, but you need a representative arterial sample. So probably in the active musculature or close to the outlet of the heart. This is still used for local flow. Thermodilution, it's really nice for local flow. Like the echocardiogram, you can get flow at the quadriceps, for instance. If you're worried about or maybe you're concerned about carbohydrate uptake or delivery of a drug, and you want just local flow. You don't want whole body cardiac output. Well, local flow is going to impact the delivery of a drug or a substance to that local area. You can't get that information from whole body cardiac output. But still, invasive. Good question. Yeah, Rosanna.
Would you be able to measure like, blood flow with an MRI?
Can you measure blood flow with an MRI? So is anything in blood magnetic? Is iron magnetic? Probably. I don't know. It's an interesting thought.
Like, I know like if someone has a cardiac thing, I don't know what it's called, the pacer, like you wouldn't be able to do like an MRI. 'Cause, like,
No.
it's messing it up, but like if
Yeah.
in these situations you're trying to like, measure the blood flow in certain areas.
Right. So the question would have to be, what practical advantage is there to doing an MRI to measure flow? And maybe there was one before, but I think it's pretty cumbersome. MRIs are usually pretty large and booked solid, right? Months in advance. My wife is waiting for an MRI of her spine right now. She had an issue with her tailbone that's been flaring up time and time again, and she got in December, and it was booked 3-4 weeks ago. So booked solid, big cumbersome machines, and I don't know what their sensitivity is like. Can you actually look at one artery only? I don't know. It's a neat question though. Yeah.
Like I know you can inject dye often in an MRI, and like, but it's mostly to look at like electrical structure.
Just the area
Yeah.
covered by the dye and not the movement of the dye?
Like they do the dye just to light up the section they want to look at.
Okay.
But they don't really use it to look at flow or anything.
Do you know, is that injection arterial or cardiovascular, or is it like in
It's just
the tissue?
It's just
Yeah, it's like subcutaneous?
it's the bloodstream, yeah. Like they'll start an IV and then
Okay.
send it, yeah.
Interesting. Well, they might be able to. Yeah. I don't know. I don't have that expertise. Yeah, question.
How quickly would you have to pull like these results in order to see the difference in flow? Because like when we were talking about how you wouldn't want to have like a catheter in an artery, obviously when you're exercising because of the pressures and the like potential
Yeah.
doing. So could you be exercising, come off the machine, do it relatively quickly, or would it need to be like real time?
If you needed the measurements, you can leave the catheter in, and a lot of research has done that. The study that I described where we took arterial measures and the plunger of the syringe was being pushed out, they had that catheter in for the better part of an hour. And we were measuring carbohydrate delivery and uptake by the muscle over that hour. So it's possible, might not be comfortable. Yeah. All right, let's leave it there because the next examples, the direct Fick and the indirect Fick, are all according to the Fick equation. So we'll explore that in detail, what it means, and the difference between direct and indirect coming up on Thursday. Okay? Have a wonderful day.